Good evening, class.
Good evening.
Good evening.
Good evening, sir.
Good evening, sir.
Hope you are fine.
We are doing well, sir.
Good. How was the midterm?
So cool.
It wasn't easy.
One said it was good. Another says it wasn't easy.
It was locally.
With the midterm there, we don't understand the marking scheme. There are some questions we got wrong. We are not sure. I think.
Did you get a marking scheme?
No, you don't have it, but afterwards you can see what you had. And some questions we are pretty sure that we had it right, but still we are wrong.
Which question did you get it right that you were marked wrong? Which question did you get it right that you were marked wrong?
Sir, we are not hearing.
No, someone says that there was a question he got it right, but he was marked wrong. And I'm asking him which question. Anyway, so let's get back to our group presentations. So the next group should.
Hello, good evening.
Good evening.
Okay, I'm Irene Gavon. I'm presenting on behalf of Group 12. And we are presenting on Hirschsprung's disease. Hirschsprung's disease is the extreme dilatation of the large intestines. It is a congenital defect and results from faulty development of the parasympathetic ganglion cells innervation of the distal bowel. This leads to ineffective peristalsis of the colon, usually the distal part, resulting in accumulation of the fecal matter and allocation of the rectum. The types of Hirschsprung's disease or the levels. The levels of Hirschsprung's disease include the first one is ultra short segment, missing ganglion cells in the last 1 to 2 centimeters of the rectum. That means the ultra short segment happen in the 1 to 2 centimeter of the rectum, the last part. Short segment, missing ganglion cells in the rectum and sigmoid colon, the last segment of the rectum. And then we also have long segments. Also, there is a missing ganglion cells in the first third of the colon. Then we also have total colonic aganglionosis, lack of ganglion cells throughout the whole colon. This level is the least common. It causes more severe symptoms than other forms of the disease. We move on to the causes or the etiology. And then this said that the exact causes of Hirschsprung's disease is unknown, but they are believed to be a combination of genetic and environmental factors. Some potential causes are inflammatory disease of the large bowel, such as ulcerative colitis, congenital defects, trauma to the colon or the spinal cord, trauma to the colon or the spinal cord. Those are the possible causes of it. So let's move on to the risk factors that predispose somebody to such condition. We said there's a genetic factors. The condition can run in families, suggesting a genetic component. If a close family member has the disease, there is a risk that the disease can occur in another family member, or the risk of occurrence is higher. Maternal smoking during pregnancy. Some studies have suggested a link between maternal smoking during pregnancy and an increased disease of Hirschsprung's disease. Gender. Hirschsprung's disease is more common in male than female. Other congenital conditions. It can be associated with other congenital conditions such as Down syndrome or congenital heart defect. Premature birth. Babies born prematurely may have a slightly increased risk. We move on to the clinical manifestation or the common characteristics that you may see. And then this is grouped in two folds. The newborn, or what you see in an infant, and then an elderly and older children. So the first one is failure to pass meconium, low pain. And then we said there will be chronic constipation, inability to pass stools without laxatives or enema. There will be abdominal distension, palpable pelvic tumor. That will be the fecal matter that accumulated, vomiting, bowel stain, or fecal matters. And then in older children, they said there is a visible peristaltic activity. There is stunted growth, explosive stool after inserting a figure into the rectum. Complications. Enterocolitis. This is a severe inflammation of the colon that can be life-threatening. It is a common complication in infants with Hirschsprung disease. 2. Bowel obstruction. The absence of nerve cells in the affected parts of the colon can lead to bowel blockages, causing abdominal pain, distension, and vomiting. Chronic constipation. Constipation is a common symptom of Hirschsprung's disease, and it can persist even after surgical treatment. Infection. Recurrent infection of the respiratory or urinary tract can occur due to the immune system being compromised by the disease. And we said the patient can also develop gastrointestinal symptoms. Patient may experience chronic diarrhea, abdominal pain, or bloating. We move on to the test or laboratory results or the investigations that are done to detect this kind of disease. 1, we have abdominal X-ray. An X-ray of the belly may show a bowel obstruction. This test is a first step. It cannot give an exact diagnosis of Hirschsprung's disease. 2, contrast enema. This test uses X-ray image and an enema solution with a contrast solution. The solution makes the features of the colon show up better on an X-ray. This is the most helpful imaging study to assist in finding out if a child has Hirschsprung's disease. Anal manometry. This test measures anal pressure. It also checks if normal reflexes of the rectum and the anus are present. It can be done at the bedside in the hospital room. Rectal biopsy. This test gives the definitive diagnosis It involves taking a sample of the cells in the rectum for pathologists to view under a microscope. The pathologist confirmed that a child has Hirschsprung's disease based on the absence of ganglion cells and other abdominal nerve-related findings. In infants, the care team does a sanction, rectal biopsy at the bedside in the hospital room. Since there are no sensory nerves at the site of biopsy, the procedure is not painful. If this is inconclusive or if the patient is older, a surgical biopsy is done under general anesthesia in the operating room. Now we move on to the nursing management. In general, we said administer prescribed stools softness. The nurse administers intravenous fluids and electrolyte as prescribed. Bowel evacuation through enema. Assess and measure nasogastric outputs. So the nursing and monitoring. Monitor for signs and symptoms of infection. Monitor patients' vital signs. Monitor and record patients' inputs and outputs. We move on to the nursing management and the health teaching. Educate patients and relatives on condition. Educate patients and patient relative on feeding the patient with soft and low residual diets. Educate patient family to feed patient with food rich in roughages. Educate patient to adhere to treatment regime. Assess for improvement in condition. Example, rectum of normal bowel sound, decreased abdominal distension. Subjective improvement in abdominal pain and tenderness, passing of flatus or two. Please, home management. Advise patient relatives to continue treatment at home as prescribed. Patient relative should administer enema to soften stools as it helps in stool evacuation. Go to prevention of the condition. It says educating pregnant women to avoid smoking as this can lead to the baby developing Hirschsprung's disease. We said it earlier that it's a risk factor. And then pregnant women should always attend antenatal visits for medical examination. Surgical management of Hirschsprung's disease. Rectal sigmoidectomy or Swinson's operation. This is the resection of the gangrenious segment and anastomosing the segment. They can also do colectomy. The lining of the diseased part is stripped away. Then the normal section is pulled through the colon from the inside and attached to the anus. Abdominal perineal pull through with anastomosis performed between normal colon and anal canal. Thank you very much. Hello.
We don't end at surgical management. It is we are doing surgical nursing. So where is your nursing management?
So please, I've said that one earlier.
Yeah. So why do we do nursing management before we do surgical management?
Sorry, it's the arrangement was not done well. Sorry for that, please.
Because before you manage, you should know what type of procedure you are going to do. And you prepare the patient for that. Then after the procedure to the post-op care. So if you don't do it that way, then you realize that the presentation is not flowing. Anyway, give them the opportunity to ask their questions.
Please, any question from the class?
No, we don't have any question. We are all tired.
No, please. They said they don't have any question, please.
Anyway, so thank you for the presentation. Respiratory disease, as you have rightly taken us through, affect the large intestine. And when this happens, they find it difficult to move the bowel. And it is usually congenital. And that is because the nerve cells that are present in the muscles to ensure that the baby will be able to move the bowel is absent. And that is why we call it aganglionic megacolon. Aganglionic, because those nerve cells are absent, they are not present. So without these nerve cells, it makes it difficult to stimulate the muscles to be able to move the bowel or the colon. And usually you may have the content backing up, and that may lead to obstruction of the bowel. And so if this should happen to the newborn, you realize that it is going to cause a lot of worry, more especially if this is the first child and they have been finding it difficult to have a baby, and now they've had a baby, and a condition like this has happened. The child is not able to move the bowel. They are going to have a lot of anxiety. So parental anxiety is one of the areas of focus in the nursing management. You know, because your child is having a swollen belly, a child is vomiting, can't really pass stools because there is constipation, you know, and that brings about the anxiety. So you really have to provide reassurance to the parents, and then let them know that it is one of the conditions that can happen at birth, but then it is manageable, you know. And they should also be educated very well on the condition. You know, as part of your anxiety management, education is very, very important. So you have to let them understand how the condition develops and what are the clinical manifestations, as well as the various management strategies that can be used in the management of the condition. When you have given them this information, it is possible that with your reassurance to their anxiety may reduce or even get relieved. All right, thank you very much for the presentation. You have done well.
Thank you, sir. You're welcome, please.
All right, so now let's move to the next group. Which group just presented?
Group 12.
Group 12.
Sir, please, group 13 you presented last
On
week.
to group 13.
Sir, last week, group 13 you presented when they were having some
When these
network
people
issues.
were having challenges.
Yeah.
Group 14, please.
Sir, last week we presented.
What was the topic? Last week we had mid-sem.
Yes. No, the day we were presenting, it was hemorrhoid.
Okay. All right.
Hello, good evening. This is Group 15 presenting. My name is Oponse Chebeneza. I'm presenting on behalf of Group 15. So with our topic, we were supposed to present on, this is the list of group members. We are supposed to present on cancer of the liver. Cancer of the liver. So cancer of the liver, according to our material, is cancer that begins in the cells of your liver. And then your liver is a football-sized organ that sits in the upper right portion of your abdomen. And then this is beneath the diaphragm and above your stomach. The liver cancer happens when liver cells develop changes or mutations in the DNA. A cell's DNA is the material that provides instructions for chemical processes in your body. DNA mutations causes changes in these instructions. And then one result is that the cells may begin to grow out of control and eventually form a tumor. That is a mass of cancerous cells. Liver cancers comes in different types. Although the two most common liver cancer types are primary and secondary liver cancer. This condition is categorized based on the characteristics and type of abnormal cells found in the liver. Cancer that spread to the liver is more common than cancer that begins in the liver cells. So literally, the cancers that metastasize to the liver is more common than cancers that originates from the liver. So cancer that begins in another area of the body, such as the colon, the lungs, or breast, and then spreads to the liver, is called metastatic cancer. That's rather than liver cancer. This type of cancer is named after the origin in which it began, such as metastatic. Okay, so sorry about the inconvenience caused by Okay, so I think I was done with the types of liver cancers. Okay. So we then move on to the causes. We move on to the causes. And then with the causes, sometimes the cause of liver cancer is unknown, such as with chronic hepatitis infections. But sometimes liver cancer happens in people with no underlying diseases. and it's not clear what causes these liver cancers. We have causes like birth defects. In this birth defects, the liver may get damaged due to birth defects. We have genetics, like if your family has a history of liver diseases, then your chances of developing liver cancer is very higher. Chronic infections. So any infection that is associated with hepatitis B or C virus can lead to liver cancers in people. And then we have chemical substances. So intake of common substances like vinyl chloride and arsenic can predispose you or can make someone cause an individual to have liver cancer. And we have rare disease. And then here, in rare diseases, liver cancer development has been linked with rare diseases like Wilson diseases and trisomia. Smoking and alcohol abuse, almighty smoking and alcohol abuse have been known to lead to liver cancer development in patients. Now we talk about the risk factors. With the risk factors, we have chronic infection with hepatitis HBV or HCV, chronic infections with hepatitis B virus or hepatitis C will increase your risk of liver cancer. Liver cirrhosis. And liver cirrhosis is the progressive and irreversible condition that causes scar tissues to form in your liver and increases your chances of developing liver cancer. Certain inherited liver diseases liver diseases that can increase the risk of liver cancer includes hemochromatosis and Wilson diseases. And we also talk about diabetes. So here, people with this blood sugar disorder have a higher risk of liver cancer than those who don't have diabetes. Non-alcoholic fatty liver disease. It is an accumulation of fat in the liver. And then it increases the risk of liver cancer since the fat is being accumulated on the liver or in the liver. And the exposure to aflatoxins. And then aflatoxins are poisons produced by moths that goes on the crops that are stored poorly. Crops such as grains and nuts can become contaminated with aflatoxins, which can end up in foods made of these products. So if these crops, these grains and nuts, you see these aflatoxins on them and then you ingest them, it can predispose you. You are at risk of contracting the disease. And then excessive alcohol consumption. Consuming more than a moderate amount of alcohol daily over many years can lead to irreversible liver damage and increase your risk of liver cancer. So it's advisable that we don't complicate things by consuming more alcohol. Complications of liver cancer. The complications are hepatic encephalopathy, the portal vein thrombosis, worsening ascites, and then varicose bleeding, objective jaundice. Here we said pyogenic liver, there will be pyogenic liver abscess, hepatorenal syndrome, it's occurrence of kidney disease due to the presence of liver disease, and then hepatic encephalopathy. Characteristics of liver cancer. Most people don't have signs and symptoms in the early stages of primary liver cancer. When signs and symptoms do appear, they may include losing of weight without trying, loss of appetite, upper abdominal pain, nausea and vomiting, general weakness and fatigue, abdominal swelling, yellow discoloration of the skin and white of your eyes. That is jaundice. So it can be white, and then you also have chalky stools. So your stools will look like chalk or the color of chalk. Diagnosis of liver cancer. We have blood test. The blood test reveals any abnormalities in the liver. Imaging test. With the imaging test, you mentioned CT scans and MRIs. They are mostly used in conjunction with ultrasound liver cancer tests to identify the extent of the outbreak. And then we have liver biopsy. So with a biopsy, we say a liver biopsy may be performed to collect a sample of liver tissues for liver cancer diagnosis in the laboratory. Cancer cells from samples are analyzed under a microscope. General treatment of liver cancer includes surgery. Surgery is often considered the primary treatment for liver cancer. It involves removing the tumor and surrounding healthy tissue. Depending on the size and location of the tumor, different surgical techniques may be used. 2, we have ablation therapies. Ablation therapies are minimally invasive procedures that use heat or cold to destroy the cancer cells. Techniques like radio frequency ablation, RFA, microwave ablation, and cryoablation can be used to target and kill the tumor cells. We also talk of radiation therapy. Radiation therapy here involves the use of high energy beams to kill the liver cells. It can be it can be delivered extremely with external beam radiation, or internally with brachytherapy. Sorry if I get it wrong. And then we also talk about targeted therapy. With a targeted therapy, it involves the use of drugs that specifically target the cells, the cancer cells' unique characteristics, such as the mutations or proteins that promote the tumor growth. We also talk of immunotherapy. With the immunotherapy, it is a type of treatment that helps the patient's immune system recognize and destroy the cancer cell. Immune checkpoints inhibitors such as nivolumab and pembrolizumab have shown promising results in some patients with advanced liver cancer. We also talk of chemotherapy. Chemotherapy uses drugs to kill cancer cells. It may be used as a systemic treatment to target cancer cells throughout the body, or as a regional treatment directly into the liver through the hepatic artery infusion, or through hepatic artery infusion. Chemotherapy is generally more effective in certain types of liver cancer, such as hepatocellular carcinoma, HCC. And then we also talk about diets. With the diet, you said you eat a variety of fruits and vegetables, which are rich in vitamins, minerals, and antioxidants. And then you choose whole grains like whole wheat, brown rice, and oats, as well as high fiber foods like legumes, lentils, and beans. Include lean protein source like skinless poultry, fish, tofu, legumes, and low dairy products. So our food habits these days has been changed. So if we can go back to our normal, the healthier food habits, it will help us prevent these conditions or treat our liver cancers. And then we said you drink plenty water throughout the day and limit sugary drinks and alcohol. Avoidance of saturated found in red meat, full fat dairy products, and fried foods, as well as trans fat food in many processed and packaged foods. We also talk about activity. By encouraging in physical activity can improve mood. It can reduce stress and enhance overall well-being. Regular exercises including strength training and stretching exercises can help maintain muscle strength and flexibility. We talk of aerobic exercises like walking, swimming, cycling. They all can improve the cardiovascular health. Talk of medication. And here medication, he said targeted therapy drugs such as sorafenib and lenvatinib are often used for advanced liver cancers. 2, chemotherapy drugs such as doxorubicin and cisplatin, they are used to kill cancer cells or stop their growth. Immunotherapy drugs like nivolumab and pembrolizumab are used to stimulate the immune system to recognize and attack the cancerous cells. And then we talk about Avastin and the likes. Okay, so we come to the nursing management. Nursing management here, we mentioned monitoring. Regularly monitor and document the patient's vital signs, including the temperature, the blood pressure, the heart rate, and the respiratory rate. And then we monitor any changes in patient's physical appearances, such as the jaundice and then the ascites that we made mention of earlier as the signs and symptoms. And then we assess the level of pain and administer appropriate pain medications as prescribed, because liver cancer comes with a lot of pain, excruciating pain. And then we monitor the effectiveness of pain management intervention and make adjustments as needed through evaluating our nursing care plan. And then we monitor for any adverse reactions to medications and provide education on managing and reporting side effects to the healthcare team. So here we tell patients to report anything, any side effects, being it desired or undesired side effects to the healthcare team, so that proper adjustments can make to patient's treatment regimen. And then we talk about the health teachings. Patients should receive education about liver cancer. Here we will include the education, its causes, the risk factors, the progression, and then the treatment modalities. Healthy lifestyle choices in the education here, the health teachings here, you ponder on healthy lifestyle choices by telling patients to, by encouraging patients to adapt a healthy lifestyle to support their overall health and well-being by doing this exercises, eating healthy diets, doing away with alcohol and smoking and fatty foods, eating more fibrous foods, among others. And then health teaching should include information on how to properly take and manage medications, including potential side effects and interventions with other drugs or supplements, because sometimes you, the nurse, you have other patients to care for. So you have to tell patients to identify these side effects and interactions and report to you as appropriate. And then patients should be educated on the importance of regular monitoring and self-care. This includes understanding the signs and symptoms of liver cancer reoccurrence or complications, such as jaundice, abdominal pain, or unexplained weight loss. And patients will be taught on forms of self-examination, such as checking for lumps or changes in the abdomen, and when to seek for medical attention. So the start teachings, in our start teachings, we found we say scheduling necessary follow-up appointments, arranging for any required medical equipment or supplies that patient may need in the home or at home, and coordinating home health care services if needed. Discharge planning will involve educating the patient and their caregivers about the medications prescribed as to how they are supposed to be administering the drug to the patients, including the time and the other side effects. Patients and their caregivers should receive detailed instructions on managing symptoms and side effects at home, and then providing information on support groups, counseling services, or resources that can help patients and their caregivers cope with the challenges associated with the diseases, because this is support groups will really help patients psychologically and socially. They will help patients a lot. And then in the support group, patients will probably meet other patients who are doing well, who are recovering, and then it will serve as reassurance to patients. And then patients will be provided with information, with contact information for healthcare team, and understand how to reach them in case of any concerns or questions. This is very necessary in our part of the world, since when you put on your TV sets, you hear people spilling lines about other health conditions. So all their concerns and questions can be directed to you, the healthcare team, or the nurse directly. Home care management also, we highlighted that we will teach caregivers on how to inspect pressure points and skin surfaces closely and routinely to prevent bed sores. We advise patients to report any unusual signs and symptoms like nausea and vomiting because of the drugs and the disease process. We educate patients on the importance of keeping the incision site free from any infection by teaching him how to care for her body without infecting the body. We encourage patients to rent caregivers to report any undesired side effects. The preventions of liver cancers are as follows. We highlighted limit alcohol consumption, maintaining a healthy weight, limit exposure to toxins, practicing of safe needle handling, practice of safe sex, vaccination against hepatitis B virus, and then quitting smoking, and screening for primary liver cancer, evaluation outcome. Yeah, we also say evaluation of the outcomes of liver transplantation involves assessing the overall health and functioning of the transplanted liver, monitoring for signs of rejections or complications, and then evaluating the patient's quality of life post the liver transplant. You have to do regular follow-up appointments, laboratory tests, imaging studies, and patient-reported outcomes are used to evaluate the success of the transplant and make any necessary adjustments for the post-transplant care plan. So this is Group 15's presentation on liver cancer and transplantation. Thank you. And then once again, we are sorry for any inconvenience that we caused today. So this is the end of our presentation.
So ask if they have questions.
Okay, so class, please, if you have any question, our group is ready to answer you. Please, if there is any question, we are ready to answer all your questions. Okay, Mr. Ahiable, you have a question.
Please, can you kindly go back to the complication? I had a problem there.
You have a problem? Okay, thank you. Okay. I was sharing a different.
I can see it.
Okay. So let me share this new slide here. Sorry, I was sharing a wrong slide. Oh God. Okay, so here is the complications.
Yeah, the hepatic encephalopathy and hepatic encephalopathy, is it a mistake, or because you mentioned it twice and you are trying to give something about it? If it's a mistake, then
Oh, okay. It was a typing error.
we can work on that. If
We will rectify it and then yes.
Okay. And the prevention, can you go to the prevention too? I saw something there that I didn't get. So
Preventions, okay.
please.
Okay. Preventions, right?
Yeah, hello.
Yeah, hello.
Yeah, it's still on complication.
You said what?
I can still see complication. The page
Really?
the page that I'm seeing is complication. Or
I don't know. Because I don't know what you don't see what I'm sharing.
no, the only thing in front of me right now is complications.
Okay. Sorry. It is here. My laptop fell over, so I'm kind of okay.
Oh,
So
okay.
here is the prevention.
It's not trying to recover from the heat.
Please, can you see the screen?
What I'm seeing, I'm still having complications in front of me. I don't know whether it's my network or what. The network here is good. My network bar is full.
It is complications that is on the screen. So.
Thank you very much.
Okay, so let me. Okay, please hold on. Let me try and do this for you.
Yes, sir.
Yes. I've copied it somewhere. Let me try and do this. Okay, so prevention is here for you. Okay, I hope you can see it now.
Yeah, I can see it. I thought I saw something that I want to. Prevention. Okay. Okay. I don't know. I thought I saw the thing in prevention, but seems I didn't jot it down. I would have just gone straight to it.
So then let's take the next person's question. Mr. Solomon, please, let's take your question. And then.
Okay, thank you.
You are welcome.
I understand that at times after transplantation of either the liver or any relevant organ, it stands a chance of being rejected. So I want to know the signs of a rejected liver after transplantation, and what are the necessary treatments? I'm sure you get me.
Yes. Yes. But sign. Please, can you come again? Your question. Please be a bit concise.
I was saying.
So literally,
I was saying, at times, when somebody undergoes liver transplants, I've heard that there can be a rejection of that organ. That particular donated organ can be rejected. So I want to know, as we are learning, what are some signs of the rejection of the liver or organ rejection, and the accompanying treatments that they use for organ rejection in case the organ rejection happens. I just want to know, please.
Okay, so if I heard you clearly, you want to know the signs of organ rejection, right?
Yes, please. That's liver rejection, and then the accompanying treatment that we can use. I didn't see it's covered in this slide, that's why.
Okay. But you see, Madam gave us where to cover. She gave us where to cover, but it wasn't part of our assignment. But I think we did certain things about that in our platform. So I'm trying to get that information.
Hello, Brian. Hello, Brian.
Yeah, hello. So please, the other group members, if you can get that information for our brother. Yeah.
Please, I wanted to say something. I don't know. It's like organ transplant is a topic on its own. Maybe
Okay. Mr. Ayable, please let me, Mr. Ayable, please let's answer. Let's answer him before. I think one of the group members wanted to speak, if I'm not wrong.
Please, some of the symptoms of the liver rejection is a high fever, an increased liver function test, yellowing of the eyes or skin, and fatigue. So it doesn't normally occur. It's 7 to 5% chances. So a 75% chance for 5 years and 35% chances for 2 years. So the rejection normally doesn't occur. So if it occurs, then we get the yellowing of the skin and eyes, the fatigue, and an increase in liver function test, and the high body temperature. Please, do you?
Yes, I understand. So in case it occurs, please, what do we do? Like the treatment?
Thank you very much, Group 15, for the presentation. Let me come in and then, because time is not on our side, and I want Group 16 to also present before the period is over. So,
Doctor, please, let me make this. Doctor, please, I want to make this clarification. Madam gave us where to present. She gave us exact things to present on, and then our presentation was not supposed to cover certain aspects. We were giving boundaries to work.
Don't worry, leave that. I said I'm coming in.
Okay, sir. Thank you.
Yeah. So, Group 15, thank you for that wonderful presentation. Cancer of the liver used not to be common. Usually when we mention cancer, breast cancer will come to mind, lung cancer will come to mind, prostate cancer will come to mind, and sometimes colorectal cancer. These are the most common cancers. Liver cancer was not one of the common cancers, but of late, it is gaining a lot of attention. And that means that people should be taking good care of their liver. So if there are any practices that doesn't help liver functioning, then one must stop, which includes some drugs that are hepatotoxic, alcohol consumption excessively, smoking, and the rest. Yeah, so liver cancer is increasing in numbers. But like they mentioned, we have primary and secondary. And usually when people report with liver cancer, it is secondary. Maybe there's a cancer in the body that has spread to the liver. But the primary ones are not really common. And one thing is that the primary ones are more dangerous and aggressive than the secondary ones. So that's one thing about liver cancer. And you should know that the most common type of liver cancer is the hepatocellular carcinoma. And we also have the intrahepatic cancer and the angiosarcoma. Yeah, also there. Then they mentioned the various forms of treatment. In fact, liver transplant is one of the forms of treatment for liver cancer. And the transplant usually you don't really get people who are willing to donate their organ, except that maybe in some few cases when people are about dying and they have a healthy liver, then they may give that instruction, take their money. And there are a lot of people in a queue waiting for one to donate. So usually it's not really common for one to really donate a liver or even to sell a liver for transplant. But before the transplant, there are compatibility checks that are done, tissue compatibility, so that when the transplant is done, there wouldn't be rejection in the new body, which is receiving the new liver. So they have to check and to be sure that the tissues of the donor, the liver tissue of the donor and the liver tissue of the recipient or the one receiving is compatible. And for that matter, there wouldn't be any rejection. All these can be done, but there can also be rejection if you don't suppress the immune system after the transplant, because there can be hyperactivity of the liver, and the immune system can also become hyperactive because a new tissue it is not used to has now been connected to it, and for that matter, it can become hyperactive and it will react to the new tissue. And usually, when it is a liver transplant and it is reacting, the reaction is like someone having a liver disease. So there can be jaundice, there can be fever, all those signs of liver disease. When one passes through, there's two color changes and all that. So those signs will tell you that there is a rejection, a tissue rejection. But usually, when they have done the compatibility checks, it may not happen that there will be that reaction or rejection. So the same signs of liver conditions will be present when one is reacting to a liver transplant. Thank you very much for the presentation. Let's have Group 15 presenting. Sorry, 60.
Good evening, sir. Yes, my name is Edijan Fibesmark, and I'm presenting on behalf of Group 16.
All right.
Okay. Okay, so the topic we are presenting on is goiter. And before we tackle goiter, we will have to know what it is about. Goiter is a condition that is associated with the thyroid gland. So quickly, we will take you through the review of the thyroid gland. Okay. So the thyroid gland is a butterfly-shaped organ located in the lower neck, anterior to the trachea. It consists of two lateral loops connected by an isthmus. The gland is about 5 centimeters long and 3 centimeters wide, and weight about 30 grams. Okay, so with the continuation, the blood flow to the thyroid is very high, about 5 milliliter per minute per gram of thyroid tissues, about 5 times the blood flow to the liver. This reflects the high metabolic activity of the thyroid glands. The thyroid gland produces 3 hormones, that is the thyroxine T4, the triiodothyronine, that is T3, and then calcitonin. So thyroxine and then triiodothyronine are referred to as collectively as thyroid hormones. And so quickly, we are now coming to tackle our main topic for the day, that is goiter. So goiter is an enlargement of the thyroid gland, which is located in front of the neck and produces thyroid hormones that regulate metabolism. There are 2 main types of goiter, that is simple and then toxic goiter. So we are coming to tackle these 2 main types of goiter. We have the simple and then the toxic. So we have a few images to appreciate what we are presenting. Okay, so the first one, we can see the thyroid gland. That's the first image. And the other images are the enlargement of the thyroid glands, which we are coming to talk about, that is goiter. Okay. So first, to tackle the simple goiter. So simple goiter refers to an enlargement of the thyroid gland, which is located in front of the neck. It is usually not a tumor or a cancer. Risk factor for simple goiter include iodine deficiency, family history, female gender, and then age. So when we talk about the age, mostly the age group that are high risk of getting goiter is like 40 and above. So simple goiter okay. So we'll now come to the types of simple goiter. And under simple goiter, we have 4 main basic types of simple goiter. The first one is the endemic goiter or iodine deficiency goiter. So quickly, the description, it's a type of goiter that is a result of chronic iodine deficiency in the diet. Iodine is an essential nutrient needed for the production of thyroid hormones. When iodine intake is insufficient, the thyroid glands enlarge in an attempt to compensate, in an attempt to capture more iodine. So endemic goiter is more common in regions with low dietary iodine content, such as the mountainous areas or regions distant from the coastal source of iodine deficiency. This is because most seafoods are high in iodine. Okay, so quickly we'll talk about the second type. That's the sporadic or sporadic goiter. Okay, so the description we have is sporadic goiter is characterized by the presence of thyroid nodules. And what about thyroid nodules? It's actually cells overgrowth, a production of cells that is found within the thyroid glands. Okay, so these nodules are non-cancerous and can cause enlargement of the thyroid. The exact cause of the sporadic goiter may vary, but can include genetic factors, hormonal changes, or exposure to environmental toxins. Okay, so we have colloid goiter as the third type of simple goiter. And colloid goiter is characterized by the accumulation of colloid, a potent substances within the thyroid follicles. This accumulation can lead to enlargement of the thyroid gland. The last one, we have the diffuse simple goiter. And diffuse simple goiter refers to the uniform enlargement of the entire thyroid gland without the presence of distinct nodules. Diffuse goiter may cause neck swelling and discomfort if it becomes larger. So we'll tackle the characteristics of simple goiter. And with characteristics of simple goiter, we have painless enlargement of the thyroid gland, visible swelling in the neck, difficulty swallowing or breathing, feeling of tightness in the throat. The complications of simple goiter can include compression of the surrounding structures, thyroid nodules, and then really the development of thyroid cancer. Okay. So we'll go to the treatment of simple goiter. Treatment for simple goiter primarily involves addressing the underlying causes. That is, if iodine deficiency is the cause, iodine supplements or dietary adjustments may be recommended. In some cases, surgical removal of goiter may be necessary for the cosmetic reasons, or if it causes breathing or swelling difficulties. Okay, so we'll now come to the other type of goiter, that is the toxic goiter. So toxic goiter, also known as hyperthyroidism, is characterized by overproduction of thyroid hormones, that is the T3 and T4, by the thyroid glands. There are several different types of toxic goiter, each with its own underlying cause. Here are some main types. So the first one, we have Graves' disease. And Graves' disease is the most common cause of hyperthyroidism. It is an autoimmune disorder in which the immune system mistakenly produces antibodies. Okay, so that's the thyroid stimulating immunoglobulins, or TSM, that stimulates the thyroid gland to produce excessive thyroid hormones. The second one, we have the toxic multinodular goiter. And this type of toxic goiter is characterized by the presence of multiple thyroid nodules or adenoma that becomes overactive and produce excess thyroid hormones independently. It is often seen in older adults. Okay, so we have toxic adenoma and the types of the toxic goiter. And this refers to a single thyroid nodule or adenoma that has become overreactive and produce excessive thyroid hormones. It is the less common cause of hyperthyroidism than Graves' disease. So the next type under toxic goiter is subacute thyroiditis, or the Quervain's thyroiditis. And this is a temporary form of hyperthyroidism caused by inflammation of the thyroid gland, often triggered by viral infection. In the early stages, it can cause hyperthyroidism due to the release of stored thyroid hormones. And we also have amidrons-induced thyrotoxicosis. Amidrons is a medication used to treat certain heart rhythm disorders, and it can cause both hyperthyroidism and hypothyroidism. And then later it refers to as amidrons-induced thyrotoxicosis. So those are the main types of toxic goiter. We'll come to the common characteristics of toxic goiter. The first one, we have weight loss, increased appetite, heart palpitation, trembling, hands, nervousness, like I am, fatigue, heart intolerance, excessive sweating, and protruding of the eyes, which is also known as exophthalmos. Then complication can include heart problems, osteoporosis, eye problems, and then in severe cases, a life-threatening condition called thyroid storm. So we'll now come to the assessment of goiter. Okay. So under assessment, we have various laboratory investigation. We also have some imagings. So under laboratory investigation, we have thyroid function test. And under thyroid function test, there are 3 types of them. So we have the first one, the thyroid stimulating hormones, and then the second one, the free thyroxine and total thyroxine. We also have triiodothyronine, that's the T3. And then also we have thyroid antibody test. And that thyroid antibody test, we have thyroid peroxidase antibodies. We also have thyroid globulin antibodies. Okay. We also have calcitonin level. So these are the various laboratory investigations that are used to identify toxic, to identify both toxic and then simple goiter. Under the imaging of thyroid goiter, sorry, we have thyroid ultrasound, we have thyroid scan, fine needle aspiration or a biopsy, iodine intake assessment, and then we have serum calcium, and then parathyroid hormones levels. Okay, so we'll come to the treatments. And the treatment approach depends on the underlying cause, the severity, and individual's patient's factor. Treatment options for simple goiter include observation, iodine supplements, and in some cases, surgical removal for toxic goiter. Treatment options include antithyroid medication or radioactive iodine therapy or surgery. We also have diets, and in both types of goiter, that is the simple and then the toxic, a well-balanced diet that includes adequate iodine is essential. Iodized salt, seafood, dairy products, and fruits or vegetables rich in iodine can help prevent iodine deficiency. We also have activities. Regular physical activity is generally encouraged, but specific modification may be needed based on the patient's symptoms and overall health. Then we'll come to the nursing management. So under nursing management, we have monitoring. That is regular monitoring of vital signs, thyroid function tests, and potential complication is important. Assessing the patient's response to medication and managing any side effects is also necessary. So health teaching and the nursing management, we educate patients about their condition, include the importance of medication adherence, dietary modification, and recognizing sign of worsening symptoms or complications, supports, and then counseling regarding body image, changes in case of toxic goiter with exophthalmos, So as we talked about, exothermos is the bulging of the eyes. Bulging of the eyes. Okay, so we also have discharge planning and the nursing management. We collaborate with the healthcare team to ensure appropriate follow-up care, medication relief, and referral for special treatment if needed. Okay, so this brings us to the end of our presentation. Thank you very much. If there is any question, I and my group members will be gladly to answer. Thank you.
Mr. Martin, please mute your mic. You are giving us feedback, please.
Hello?
Yeah. Hello?
I think I'm back.
Hello, Mr. Bismarck, you can talk here. Please, we are listening to you.
We are done. We are done. So I said if there is any question. Okay. So please, we are done.
No questions? Anyway, if there are no questions, that's fine. Thank you, Group 16, for the presentation. So, goiter in general can have several factors that are responsible for its development, but the primary one we know can be the dietary. However, goiter can be physiological and it can also be pathological. That is one thing we should know. So it could be that the enlargement of the thyroid gland is a physiological response to a change in the body. And it could also be that the enlargement of the thyroid gland is as a result of a disease condition. So that's why we are saying it can be pathological or physiological. So it has something to do with the hypothalamus. It has something to do with the anterior pituitary gland, and it has something to do with the thyroid gland itself, and it has something to do with diet. So any of the courses you take, you realize that in trying to explain, you come across any of these that I have mentioned. For instance, the enlargement could be that there is a excessive secretion of the thyrotropin releasing hormone, which is produced by the hypothalamus. And you know that it is the thyrotropin releasing hormone that usually will cause the secretion of the thyroid stimulating hormone, which is produced by anterior pituitary gland. So this thyroid stimulating hormone also stimulates the thyroid gland to secrete the T3 and the T4. So imagine if there is a problem at the hypothalamus and there is excessive secretion of thyrotropin releasing hormone, that means there will also be excessive secretion of the thyroid stimulating hormone. And that also means that there will be excessive stimulation of the thyroid gland. And that means that there's going to be excessive secretion of the T3 and T4. Anyway, so the excessive stimulation of the thyroid gland can cause it to swell up and enlarge. And that brings about goiter. And in toxic nodular goiter, you know that there are small rounded mass or masses that are seen, and that is the nodules. And it is the nodules which produce too much of the thyroid hormone. So in such goiters, you are going to have excessive T3 and T4, and that means that it is going to lead to speed metabolism and production of heat. So because T3 and T4 has calorigenic effect, and that means that there will be heat production at the end of the day. So once you have excess T3 and T4, that means there is hyperthyroidism, and that is going to lead to the nervousness, the restlessness, the heat intolerance, and increased sweating, the fatigue, the weight loss, because whatever is taken is metabolized at a very high rate. There is much speed because of excess T3 and T4. So the manifestations of toxic nodular goiter is like it happens in hyperthyroidism. If you remember the manifestations of hyperthyroidism, you will also remember the manifestations of toxic nodular goiter. You have treated it well. Thank you very much for the presentation, Group 16. I saw Group 17 saying that they've not been given a topic yet. Have you, Class Rep, have you contacted Ms. Romana? Class Rep.
Hello. Hello, boss.
Have you contacted Ms. Romana about Group 17?
Group 17. It was just evening while I
can't hear anything again. I don't know if I'm the only one who can hear. Hello? Okay, please. I don't know if you can hear me. So that group, Class Rep, can you contact Ms. Romana? But that group hasn't been given a topic. But I'll also talk to her. And so that we will know the topic to 17 to present on. So that will bring us to the end of today's class. Thank you very much for coming. See you next week when I see you.
Thank you. See you too, sir.
Thank you, sir.
Thank you, sir.